Welcome. This session covers utilization management, how healthcare organizations balance cost and quality by getting patients the right care at the right time in the right place. Why does utilization management matter? Wide variation in medical practice often signals that resources are not being used appropriately. Overtreatment, undertreatment, and the wrong interventions are all forms of wasted resources that harm patients and inflate costs. Practice variation persists because payment incentives pull utilization in opposite directions. Fee-for-service models often encourage overuse, while capitated payments may tilt toward underuse. These imbalances create the need for an oversight function. The principal objective of utilization management is to reduce practice variation. By using clinical practice guidelines and pathways, the organization ensures resources are used cost-effectively and patients receive the most appropriate care. The evolution of this field shows a shift from retrospective review to active management. Prospective payment systems like DRGs were the primary driver, forcing providers to control costs and embrace administrative review for appropriateness. It is important to distinguish between utilization management and utilization review. is the broad, ongoing function of managing resources. UR is the specific activity of evaluating necessity and efficiency against benchmarks. Who performs these reviews? It can be the provider's own staff, the managed care organization's team, or an independent, third-party review organization. Each has a role in verifying that the care provided is justified. When a reviewer has a stake in the outcome, such as when an organization reviews its own performance, conflicts of interest can arise. Independent review organizations act as a vital safeguard against potential bias. The team pairs nursing and physician expertise. Nurses perform first-line reviews and discharge planning, while physicians provide clinical opinions and peer reviews for complex or disputed cases. Accountability is a top-down process. The board holds ultimate responsibility, while a dedicated department or committee plans and implements the program to ensure efficient, high-quality patient care. Core responsibilities include medical necessity reviews, ongoing surveillance for usage patterns, discharge planning, and constant staff education to reinforce cost-effective practices. The process follows 3 steps: initial nurse-led review, physician-led peer review for complex cases, and an appeals process for non-certification. Importantly, only a physician can deny a service. Explicit criteria protect both sides. They ensure patients receive necessary care without excessive burden, and they help payers guard against financial loss by ensuring services meet evidence-based benchmarks. Utilization is managed across 3 distinct timings: prospective review before the case, concurrent review during active care, and retrospective review after discharge. We begin with prospective review, which involves managing cases before treatment begins. This is where pre-certification and same-day surgery planning take place. Pre-certification requires physicians to notify the health plan before an inpatient admission or outpatient procedure. This process documents the need for care, helps direct patients to the most appropriate setting, improves financial forecasting, and verifies member eligibility. There are key exceptions. Emergencies don't require pre-certification, though notification must follow by the next business day. For out-of-network care, the burden of authorization shifts to the member, and skipping this step can lead to financial penalties. Pre-admission testing and same-day surgery are effective for managing elective cases. By performing tests as an outpatient earlier in the week, hospitals avoid unnecessary overnight stays, effectively controlling costs while maintaining quality. Moving to concurrent review, this is the process of managing utilization while the patient is still in the hospital. It is widely considered the most effective form of inpatient control. Concurrent review relies on 3 primary techniques: tracking length of stay against diagnosis-based benchmarks, gathering real-time case information for internal teams, and conducting daily in-person rounding on hospitalized members. Tracking length of stay provides established authority to manage costs. While it simplifies negotiations, it must be balanced with case mix and risk adjustment to ensure the guidelines fit the individual needs of each patient. Effective information gathering involves the nurse collecting and routing vital data, like diagnoses, specialists involved, and discharge needs, to the right medical and financial teams to ensure coordinated care. Daily rounding allows nurses to inform discharge plans early, detect convenience-driven delays, and boost member satisfaction. Although some facilities may restrict these privileges, consistent rounding remains a powerful management tool. Retrospective review occurs after a patient is discharged. This involves looking back to perform claims reviews and pattern analysis to ensure services were billed appropriately. Claims review uses software to flag potential errors, while pattern review compares performance across providers to identify outliers and outcomes and charges, helping to steer future care to top performers. Case management is the final program we will discuss. It coordinates care for the most complex, high-cost patients to ensure better clinical outcomes and significant cost savings. Case management is a collaborative process that assesses, plans, and monitors the services a patient needs. It targets the most intensive cases, spanning the entire continuum of care, using all 3 review timings. The case manager is typically a registered nurse who functions as a facilitator, problem solver, and skilled negotiator. These managers can be assigned by the hospital, the MCO, or directly by the patient. Why focus so much effort here? A small group of patients, often 3 to 5%, accounts for the vast majority of healthcare costs. Proactive management of these cases is essential for any organization. Successful case management creates a win-win. Patients receive the best care within their coverage limits, while the organization sees a strong return on investment, with savings ratios as high as 1 to 30 for every dollar spent. Next, we focus on discharge planning. This is the mandatory process of engineering a safe, efficient transition out of acute care, starting from the very first day of a patient's admission. Discharge planning is a regulatory requirement for all inpatient cases. It ensures each patient receives a customized transition plan, coordinates follow-up care like home health or equipment, and prevents unnecessary, costly readmissions. Effective planning starts at admission, or even earlier during pre-assessment. By estimating the expected outcome and booking necessary resources like rehab beds or home equipment early, we prevent avoidable delays. Think of the discharge planner as an orchestra leader. While the attending physician, nursing staff, family, and patient all play their parts, it is the planner who coordinates everyone to ensure a seamless transition. Medication reconciliation is a vital component of discharge. It resolves discrepancies in dosage and frequency that often occur when patients transition between care settings, helping to prevent adverse drug events. Our next program is disease management. This focuses on caring for the entire continuum of a chronic condition, from early identification to long-term monitoring, for as long as the disease persists. The goal of disease management is population-based care. Identify those at risk, apply proven programs, and measure outcomes. Success means reduced disability, a better quality of life, and lower costs for chronic conditions. Disease management follows 6 steps: building a comprehensive data set, setting evidence-based benchmarks, calculating ROI, segmenting patient populations, identifying variations in quality, and piloting strategies to win clinician support. Ideally, we intervene before a disease fully manifests. By analyzing genetic factors, family history, and routine screening results, we can often address risk factors early, preventing the development of chronic illness. Our final program is demand management. This strategy focuses on reducing avoidable needs by empowering members to make informed, appropriate decisions about how and when to seek care. Demand management balances access and cost. By supporting members with the right information, we reduce unnecessary service utilization, improve patient satisfaction, and ensure care is sought appropriately when needed. Demand is driven by 4 factors: actual morbidity, the patient's perceived need, personal preferences, and social influences like employment or income. Effective management addresses these drivers through informed member self-care. Demand management tools include nurse advice lines, self-care guides, online education, and preventative services like screenings. These resources help members distinguish between emergencies and conditions manageable at home. In summary, utilization management acts as the umbrella for all these activities. By aligning review timings with case, disease, and demand management, organizations achieve high-quality, cost-efficient, and effective care. Remember, eliminates utilization extremes, reviews care at every stage, targets high-cost outliers, plans the discharge from day one, and actively manages demand. These elements together ensure a balanced health system.